Comprehensive, relevant, and insightful conversations about health and medicine happen here on MedStar Health DocTalk. The hand is a unique part of the body. During World War II, it was often required that a vascular, neuro, orthopedic, and plastic surgeon be brought together for a singular traumatic hand injury. It was then that hand surgery emerged as its own medical specialty. Today we're talking with Dr. Ryan Katz, an attending hand surgeon at Curtis National Hand Center at MedStar Union Memorial Hospital in Baltimore, to learn more about complex reconstruction of the hand. I'm Deborah Schindler and your host. Dr. Katz, welcome to MedStar Health Doc Talk.
Thanks for having me.
To give a little backstory, Union Memorial Hospital has been at this location with patients coming to see Dr. Ray Curtis for hand surgery shortly after World War II. It wasn't until 1975 that the Curtis National Hand Center was formally established. So now the Curtis National Hand Center is nearly 50 years old. Is it safe to say that it's the largest in the world?
That's a good question. It definitely has a storied pedigree. It's probably one of the oldest hand programs in the world. It's probably one of the strongest hand programs in the world. I mean, there's 14 surgeons affiliated with the program. We train fellows every year. We train the Army hand surgeons and have been doing so since Ray Curtis. So definitely a premier hand center and has carried that reputation since its inception.
With a focus on education, which means what, really?
Yeah, so we train orthopedic surgeons and plastic surgeons to be hand surgeons. So like you were saying in the very beginning, historically, because there's so much going on in the hand, bone, tendon, nerve, soft tissue, it would take vascular surgeons, orthopedic surgeons, general surgeons, like there was no one hand specialist. They were kind of generalists that would operate on the hand. So we train people to be hand specialists. So they focus on the hand day in, day out. So if there's a hand problem, they understand the anatomy, they understand the pathology, the mechanics of the hand, what is going on, how best to fix it. And the surgeons that we train leave here with adequate training in skeletal fixation, so they know how to fix bone, vascular reconstruction, they know how to sew arteries. We're talking brachial artery, which is about the size of your pinky, radial artery, which is probably the size of a pencil, digital artery. Now you're in the micro level, 1 to 2 millimeters in diameter. They know how to work under the microscope, fix tendons, deal with challenging soft tissue defects in and around the hand and fingers, focus on function, things like that, things that you would not get from a dabbler, if you will.
Just an orthopedic program or a surgical program.
Yeah, I mean,
you came here as a plastic surgeon into the fellowship program, right? And is there a difference in plastic and reconstructive surgery and just plastic surgery?
Yeah, that's a good question too. And I just want to clarify when I say dabbler, which I know is a funny term. It was purposefully chosen, though, to reflect the fact that I think if you're going to have something complex done on your hand, you should go to somebody who trained in hand surgery. That means they completed whatever they completed and then did a year of extra training in hand surgery, or they completed their plastic surgery training and then did a year of extra training in hand surgery. And by the time they're done with their extra training in hand surgery, plastic surgeons and orthopedic surgeons, they have a very similar skill set, and they are both experts in dealing with the hand. Now, to answer your second question, is there a difference between plastic surgery and plastic and reconstructive surgery? When you're training in plastic surgery, you are learning the art and science of plastic and reconstructive surgery. So you're learning about soft tissue handling, soft tissue reconstruction, and aesthetics, form and function. So you learn all aspects of plastic surgery. You're doing the aesthetic surgeries in addition to the complex sarcoma reconstruction or something like that. So you learn everything. And then when you're done with your plastic surgery training, you get to choose. Are you going to be an aesthetic surgeon? Are you going to focus on some reconstructive aspect of surgery? Or are you going to do a subspecialty like hand surgery? So there are many plastic surgeons who shoot off from plastic surgery. They do extra training in hand surgery, and then that's the focus of their practice is hand surgery. Now, most of those plastic surgeons really enjoy soft tissue reconstruction. and complex cases.
Like yourself. So before we get to that, I do want to ask, when you were in medical school, did you know you wanted to be a surgeon?
No, I did not want to be a surgeon.
You didn't want to be a surgeon?
No.
Really? That surprises me. Wow, you went from you went to the extreme then to become
I did.
Complex and reconstructive surgeon.
I went to the extreme.
What changed your mind?
Yeah, it was really late in medical school.
What kind of surgeon or what kind of doctor did you want to be?
I wanted to be an internal medicine doc.
Okay.
Yeah.
And then something happened, or?
Yeah. I was exposed to really interesting plastic surgery procedures on one of my medical school electives. And I thought, wow, geez, I didn't even know this was a thing. Because I think when a lot of people think about plastic surgery, they just think aesthetic.
Right.
But that is not the case.
Breast implants.
Yeah. Yeah. And, Botox and fillers. But that is not what's happening.
What was happening in that case that?
Oh, man, you name it.
Attention?
Well, you name it. I mean, the guy I worked with, he did everything from cleft lip, cleft palate. So, I mean, if you've ever seen a child with a cleft lip, and then at the end of the case, it looks like they have a normal lip, I mean, that'll blow your mind.
Wow.
Hand and upper extremity replants, hands ripped off and put back on. Free tissue transfer with functioning muscle. So, you take a paralyzed extremity and you bring muscle from one place and move it to another while keeping it alive the whole time. And then you reinnervate it and restore function. And I mean, it really just appealed to me, just the fact that you could even do this stuff.
So you got out of medical school as a plastic surgeon or plastic and reconstructive surgeon.
Well, so at the end of medical school, I'd switched and said, I didn't want to do internal medicine. I want to do what these guys are doing. I want to do plastic and reconstructive surgery. That just really.
But you always knew that you wanted to do the reconstructive part. You didn't know that yet about the hand surgery.
Oh,
or did you?
Yeah. I liked everything about it. I liked everything about it. So after medical school, I trained in plastic surgery at Johns Hopkins and University of Maryland. It's a combined program. So, you spend time at both institutions, and that gives you access to shock trauma as well. I mean, I just liked everything about it, even the aesthetic side of it. I liked it all.
So at what point then did you decide to do your fellowship? And you applied here at the Curtis National Hand Center.
Yeah.
Right?
Yeah. So as I was going through my training at Hopkins, we did a rotation here at the Curtis Hand Center. So I was exposed to high-level hand surgery as part of my training. And I thought, wow, this is it. It was just like a puzzle piece finally fitting. It was everything that I was looking for. It was the small vessel work, the large vessel work, the bony work, the nerve work. I mean, it was everything. Hand surgeons, I think, and of course I'm biased, but, by the time you're done with your hand surgery training, and that's whether you've done your orthopedics first or plastic surgery first, you kind of feel that you could handle just about any tissue that comes your way. You can put tendon together and put nerve together and sew vessels together. And I really liked being able to do that.
What do you like best?
My favorite case?
Yeah, what's your favorite case?
Well, I love rebuilding thumbs. I think that is just...
Explain that.
Well, there's lots of ways to rebuild a thumb. If a thumb has been amputated in some way, I would love trying to put it back on. If you can get it back on, that's a real win for the patient. And oftentimes we can, that's great. That's great all around. It's very rewarding as the treating physician, and it's very rewarding for the patient. But sometimes you can't get a thumb back on, and then you have to figure out a way to rebuild the thumb. And there's a way that's been around for a couple of decades, which still can garner headlines because it's so interesting. I mean, patients just...
You're talking about toe-to-hand transfer?
Yeah, you beat me to the punch. Yeah, the toe-to-hand transfer. I mean, that procedure has been around for just about as long as microsurgery has been around. So we're talking decades. And still, when you do it, it blows people's minds because...
Because what's happening? Explain what's happening to someone who hasn't heard about what it is.
If your thumb has been amputated, and we can't put it back on, or you have failed other modes of reconstruction, you could have your thumb rebuilt with your toe, your great toe. And we can take the toe in such a way that it's really a minimal hit to the foot. I mean, that's the concern is, don't I need my great toe?
And by great toe, you mean big toe.
The big toe.
You guys call it the great toe, but most people call it the big toe.
Well, I mean, the terms are very interesting. So we'll call it the great toe to kind of show it the respect that it deserves. We will call the small finger, not the pinky. Hand surgeons don't call it the pinky. To show it the respect that it deserves. So yes, we would take the great toe or the big toe and then move it up to the thumb position. And because we train in microsurgery, you can sew the toe artery to the artery that otherwise would go to the thumb and the hand. And you can sew small veins of the toe to small veins in the hand. And you can fix the skeleton and fix the tendons, and you can rebuild the thumb.
And I know you've done this with children, so it grows still.
Yeah, that's a very interesting and fascinating subfield in hand surgery. What you're talking about is something called physeal transfers, where you can actually take a growth plate in a growing child and move it from one location to another to augment growth or correct a growth deformity in a growing child. But fortunately, kids are not losing their thumbs with the frequency that adults are losing their thumbs. So a great toe to thumb reconstruction in a kid is less common than a second toe to extremity reconstruction to correct some deformity or something like that. So you could take any toe. The great toe just happens to be, for most people, it's a really nice way of reconstructing the thumb.
But that would surprise most people. Like, if I didn't see the end result of those surgeries, I wouldn't think that a big toe could match. I mean, the great toe could actually replace a thumb. That I would think that the second toe, would be a better replacement because it looked more like a finger.
Yeah. The second toe is a better option for finger reconstruction, fingertip. But it's not a wonderful option from an aesthetic standpoint for a replacement for the thumb. It just doesn't look like a thumb. But most people's great toes look like a thumb to some degree.
With subsequent surgeries.
You can,
right?
At the time that you're bringing it up, you can do certain maneuvers to make it look even more like a thumb. But some people's great toes look remarkably like their thumbs. And then there are some people who there's no helping them. There's just no way.
But the point is that they regain function, right? Because...
See, this is what appeals to the plastic surgeon and the reconstructive surgeon. It doesn't just do function, it's form and function, right? It gives them a 5-fingered hand with an excellent aesthetic. I mean, there are some cases I can show you and you would have no idea that this was their toe. You would have no idea.
They don't miss it on their foot. They can walk just fine.
Yeah. Yeah. I mean, it's always a risk. I don't want to say there's no risk to this surgery. It's a technically challenging surgery. And there's always the potential for failure of the reconstructive effort. There's always a risk of pain at the recipient site or pain at the donor site. But we haven't really seen that. I think that's because you do one of these surgeries, you're really zoned in. I mean, everything has to go right.
How soon do you know that it's been successful after the surgery is complete?
Yeah, these surgeries are really interesting in that when you harvest the toe, there's a brief period of time where there's no blood flow to the toe, right? You have to get it from the foot to the hand, and then you'll stabilize the skeleton and fix all the soft tissues, including the tendons, and then you'll sew the arteries and the veins together under the microscope, and then you'll release the clamps at the end of the case, and you'll see a pale toe turn pink. The color will return. And so you'll know at that point whether or not the toe is going to live, usually. Have
you found that patients come in with a misunderstanding about complex reconstructive hand surgery?
That's a good question. I think that patients might not recognize the importance of being seen and treated at a hand specialty center. That's a misunderstanding, where you think, okay, well, a generalist can do this complex reconstruction. Sometimes that is a miscalculation that potentially can get you into trouble. I'm not saying that, hand surgeons never have issues or complications. That's not true. I mean, every surgeon has complications, things like that. But I just think that you can really tilt the odds in your favor of a better result if you go to someone who does this all the time at a program where they do it all the time with 14 docs, who do it all the time, and a therapy center that's right next door. Hand therapist, certified hand therapist, meaning even the therapist did extra training in hand surgery.
Explain to the listeners what a flap surgery is and why sometimes it may involve attaching a hand to the patient's groin.
Okay. Just like how the surgeon calls the big toe the great toe, they call the groin basically the bathing trunk area. So when the layperson thinks of the groin, they think of the central groin. But when the surgeon talks about the groin or the groin flap, they're really talking kind of lateral thigh, hip area. So if you were to tell the layperson, well, I'm going to attach your hand to your groin for 3 weeks, they're going to be freaked out a little bit.
But even to have their hand attached to their thigh for 3 weeks.
They might be freaked out, but they're less freaked out. If you say, I'm going to attach your hand to your thigh.
Explain why that happens, because that, I think, is an extraordinary step in the process of some of these reconstructive efforts.
Right. Interestingly, that procedure has been around forever. That is not a modern day procedure. That's an old school way of transferring tissue from one place to another.
Understand what a flap is.
Yeah. So a flap is a piece of tissue that is harvested from one area and used to cover or reconstruct another area.
So give me an example of a patient who would come in with what type of injury that would need a flap.
So let's say you had a rollover motor vehicle accident, your hand was out the window, and all of the skin on the back of your hand and arm was scraped off, and you're looking at tendon. You can't close that wound. You can't just
pull it together.
Yeah, you can't pull it together. So you need to cover over it with skin. And now there's tendon there, maybe some exposed bone. You can't put a skin graft on it. That's going to be a terrible result. So what you really need is to replace what was lost. And what was lost was skin and fat. So you need skin and fat from somewhere else in the body. Where can you take skin and fat and get away with it? Well, the lateral thigh. That's one place. So you could elevate skin and fat from the lateral thigh, groin area, and you can move their hand down to the groin hip area. And that skin that you elevated, you could just lay that right down on the hand, suture it in place, and leave it in for 3 weeks. And doing so allows that skin to develop a new blood supply to the hand. And then you can detach it from the groin lateral thigh area. And it is now living on the hand.
So it's to keep it alive while it's healing.
Yeah. The only way to do it acutely, meaning you don't have to attach the patient to the groin lateral thigh, would be to do microsurgery, where you actually elevate the skin, looking for a very small artery and vein going to the skin. Once you find that artery and vein going to the skin, you then take it down to its source. And then you clip it, cut it. You can then move that tissue en bloc up to the hand. And then you have to sew the artery and the vein together to a new location. So you're moving the skin to a new location and moving its blood supply with it. So microsurgery allows you to free up the hand and the extremity. But why would you attach somebody to their thigh or their groin area? It would be to avoid microsurgery for some reason. And one of those reasons would be this person needs staged reconstruction. So you can put the skin on the hand, keep them attached to the groin. You aren't using any blood vessels that you might otherwise use for their future reconstruction. That's one reason. Another reason might be that you don't have the capability or the tools that you need to do microsurgery. So that's called a pedicled flap, where you leave it attached.
And when you talk about microsurgery, tell me a little bit about that. The thread that you're using, I've heard you guys describe them to be pretty small.
Oh, yeah, they're very small. Yeah, they're at a minimum the width, well, maybe at a maximum, the width of a human hair. And then they get smaller. So when you're dealing with, let's say you cut off your fingertip or something like that, you might look to put it back on. You need a suture that's really small. Suture is typically measured in O's. So they'll say like 4O. 4O is commonly used to close skin of all over the body. 4O, that's like a common way to go. For injuries around the face, we use smaller sutures. So you're on the order of 6O. So you're getting pretty small. And then for nerves around the hand and wrist, we use 8O, getting even smaller than that. And then for finger stuff, we'll use 9O, 10O, 11O.
Because the nerves are smaller than vessels?
No, the nerves are usually larger than the vessels, but it's the vessels that require the really small sutures. I think the new thing is nerve transfers. That has really made significant headway.
What does that mean?
That's where you take an expendable nerve, an expendable working nerve, and you can transfer it to a muscle that is not working, essentially. So if somebody has an acute paralysis as a result of trauma, you can take a nearby muscle that has multiple points of innervation, and you can clip one of the nerves that's working and slide it over to the muscle that's not working and suture that nerve together. And then that nerve will grow into the muscle that's not working. And you can get a not working muscle to work.
Is that happening in hand surgery?
Yeah.
Give me an example of a hand case that might come in. Why would the patient need that?
Yeah, so if someone has like a motorcycle accident or something and they have a partial brachial plexus injury and certain groups of muscles are not working, so your digital flexors are working, but your digital extensors are not, and your wrist extension is not there, or your elbow flexion is not there. You know, these are lost motions that can cause significant disability to the upper extremity. You would take an inventory and say, okay, well, what do I have that's working? And is it potentially expendable? You know, previously we would do tendon transfers where you take a working tendon and you move it. But now we're at the point where we're actually borrowing nerves from working muscles and moving it to non-working muscles. So, you know, in that patient, that motorcycle accident patient I was telling you about, sometimes you cannot reconstruct the injury up here at the level of the brachial plexus, which is at the level of the neck. And if you did, it might take too long for that nerve to recover. The muscle might die in the interval, the downstream muscle. If it's not getting its innervation, it becomes flaccid, fibrotic, just basically stops working, and you can't reclaim it once you've lost it. So if you could go downstream from the injury and transfer a working nerve to it, you can get that muscle working again.
Is transferring a nerve the same as transferring a tendon in that it needs its own vascular supply brought with it?
No, the nerve that you transfer, it has its own vascular supply. There's small vessels that run with the nerve that keep it alive.
Okay. Explain to me what the congenital hand clinic is.
That is a monthly meeting that we have where children are brought by their parents. These are children with congenital differences of the hand. So they might have bowing of the forearm or fingers that are fused together or some clinical deformity that the parents are interested in addressing, or some functional problem that the parents are interested in addressing. And alongside of that, we'll also see children and adults with complex cases. So these could be post-traumatic cases, people who have been seen and treated elsewhere, maybe with ongoing issues or ongoing questions, really challenging upper extremity problems. And we'll meet once a month. We'll see every patient individually. All 14 of us will get together, plus the hand fellows. There's plastic surgeons in the group, orthopedic surgeons in the group. There's oftentimes therapists there. And we will all see and evaluate the patient and then come up with a consensus opinion. Can we help the patient? How? What's the best treatment plan? And then we'll contact the patient and say, thank you for coming in. This is the consensus opinion of the group. This is how we think we can help you out.
What a great opportunity for parents, really, to have so many experts on this subject.
Yeah, I think it's great for parents. I think it's great for the children. And I personally like how it has morphed from a purely congenital clinic to a congenital and complex case clinic. So even adults with complex upper extremity problems can be seen in this clinic.
One congenital hand difference that has brought a large amount of media attention to the hand center, and specifically to you and Dr. James Higgins, the chief, is what is called club hand. Tell me about the significant surgery that you do. We
were talking about the subfield of physeal transfers. These congenital hand differences, this club hand, that's a rare problem. And it's a challenging problem to treat. So these are children who essentially are missing one of the two bones of their forearms. So there's two bones in the forearm, the radius and the ulna. And for radial club hand, they're missing their radius or a significant portion of the radius. And as a result, the ulna keeps growing, but the radius is kind of tethering the ulnar growth. And so the whole hand gets curved, or the whole arm gets curved towards the thumb, essentially. And how much use does that child have of their hand? Yeah, these kids are great adapters. They'll always figure out a way to use what they have. The question is, can you make it better in some way? Mm-hmm. Can you restore longitudinal growth, add function maybe some function that they didn't have, maybe improve an aesthetic. There's no doubt that a bowed, curving forearm is going to draw unwanted attention. And so if you can provide some sort of longitudinal growth, more balanced growth, that's going to draw less unwanted attention. So in this case, we transfer the second toe from the foot and implant it into the forearm. And the thing about the second toe in kids is, first of all, it's an amazing donor site. You can, when it's all said and done, it's really hard to even tell on the foot that you had a surgery done, with the exception of a longitudinal scar. You can still wear flip-flops, and I wouldn't expect any issues with walking, though that is always a risk, but I think it's a low risk. You can take that second toe, and that second toe comes up with bone, joint, and growth plates. And if you can restore the blood supply to the second toe, just like restoring the blood supply to the great toe when you put the great toe in the thumb position, that blood is flowing through the bone, through the growth plate, through the...
Amazing.
Yeah, it is amazing. So, this bone that you've transferred from the foot up to the forearm, it will grow. It's not static, it will grow. So it affords you the opportunity to have more balanced growth of the forearm and minimize the bowing. You cannot make that forearm perfect. And these children often do need revision surgeries as they grow. But that really is kind of frontier, vanguard type surgery. Only at an institution like this, you're going to get this really innovative, technically advanced surgical solution to this and these challenging problems. Only at a place like this.
Excellent. We have to talk about leech therapy. I cannot talk about complex surgeries of the hand without talking about leech therapy. It's a very skeevy subject, but one that still is fascinating to think about, that they're being used in modern medicine. Where do they play into things?
Yeah.
And how often do you actually use them?
Well, they're still used pretty frequently in reconstructive surgery. And I just want to say that leeches have been in use for thousands of years. And it's fascinating that they still have a role in modern medicine. So it's not a modern concept by any means. Right. But we still use maggots too, maggot therapy, as a way of getting rid of dead and devitalized tissue in a painless way. Painless. Yeah. It's just fascinating. The whole thing. It is fascinating. Right. See, that's the sort of thing.
So you're not using the leeches though for bloodletting, right?
Well,
it's for blood flow. Explain how they're applied.
I'll explain it. So when you disconnect tissue from one place and put it to another, and you sew the artery and you sew the vein, and you release the clamps, and you see this pale tissue get its blood flow back. Oftentimes, that's it. That looks great. Everything is off and running, and things are going well. But sometimes what can happen is the arterial inflow can exceed the venous outflow. It's like a big traffic jam, and the flap will start to look sick and swollen and tense. It does not look healthy. Yeah, I think you're asking, why would that happen?
Yeah, why would that happen?
Yeah, sometimes that happens because they formed a clot in the vein, in the outflow vein, or the vein is kinked. I mean, everything has to go right. One thing that's off, it could just throw the whole thing off balance. And if there's a discrepancy between inflow and outflow, the flap will become engorged. That venous blood has nowhere to go, and that could kill your flap.
So you come in and you see the patient's fingertips through the bandages are not pink, but they're purple.
Right. So if we replanted your hand, if your hand was ripped off and we put it back on, and I come and check on you a couple hours later and your hand looks purple, that tells me your inflow is good, but your outflow is bad. And now we have options here to treat you. Either we go rushing back to the operating room and I look at your veins and I fix the veins, and that would be my preferred option. Or you could consider another off-road for this traffic jam, and that's how do we get the blood out of there? You see where this is going.
So you order up some leeches.
You put a leech, yeah.
Where do you get them from? The pharmacy? I mean, you're not going down to the swamp and getting leeches.
No, right? Yes, these are medicinal leeches. Mm-hmm. They're ordered from a company, and we have them here in the hospital.
So under what circumstances, maybe you've already been to the operating room and now it's purple again?
Yeah.
One?
Yeah, exactly. Or for some reason, let's say, you were under anesthesia for 8 hours to get this extremity back on. And we thought, well, it might not be safe for you to return to the operating room for more anesthesia. You know that you have an alternative method of allowing for the venous blood to get out of the flap. So that would be...
So how do they actually help, though? What is actually happening with these leaks?
Yeah, so there's two things that happen. Number one is they take blood off. It is like classic bloodletting. So they will decrease the blood volume, the tension in the flap. And then number two, in the leech saliva, they have something called hirudin, which is an anticoagulant. And so once the leech falls off, you'll see dripping around the leech bite mark for several hours, usually, anywhere from like 2 to 4 hours of dripping from the leech bite site. Now, in the wild, that probably calls to the leech buddies in the river, hey, there's blood here, come on. And it probably helps the leech feed. From a medical standpoint, it is a nice way to prevent that venous hypertension, that venous congestion that you see. So you get that initial bloodletting, and then you get that persistent ooze that you're looking for because you need an off-ramp for that venous blood.
That it's flowing.
Yeah, it's flowing, and it is preventing the traffic jam.
And it probably doesn't hurt because their nerves, I don't know, does it hurt?
No, it does not hurt.
No pain.
Yeah, in addition to the hirudin, there's an anesthetic in the leech saliva as well, so it doesn't hurt. Even if you put it on intact skin, you might not even be aware.
Oh, wow.
That the leech
I did not know that.
Yeah.
What would you say is the most exciting thing on the horizon of complex hand surgery? And what does it mean for patients?
You can take not just a heart from a cadaver, a living donor, brain dead, deceased, heart, lungs, kidneys, all this stuff you're used to hearing. But you can also take tissues now, like hands, faces, and you can transplant them from a recently deceased donor to somebody in need. So somebody with a bilateral upper extremity amputation.
Which you've done.
Yeah.
You've been a part of.
Yeah.
And there's a lot that goes into that.
Yeah.
Until I had no idea you have to consider this bone size and the flesh color.
Yeah.
I mean, why would that be important?
You don't want to draw unwanted attention.
I guess there's a psychological impact on the patient if they're constantly looking at a hand
That's true. Yep. You don't want the patient to think that the hand is not part of themselves. You really want a seamless integration. So if you're going to transplant a hand from a recently deceased person to somebody with a hand amputation, you really need that acceptance and that seamless integration.
Do they have to take a cocktail of immunotherapy drugs for the rest of their life? Yeah,
but people are really trying to figure out how to be minimalistic in that way. And even though you'll start with kind of a whopping dose, there are protocols out there now where you can get down to just one pill once a day.
That's extraordinary.
It is extraordinary. I mean, we've come a really long way. Even still, there are risks to taking an immunosuppressive agent for the rest of your life. So really the holy grail is tissue tolerance, something where ultimately you can get off the immunosuppression. And there are some tantalizing things in the real world where there are some kidney transplant patients who are non-compliant with their medicine and don't reject their organ. That's a fascinating thing. And I do not recommend transplant patients stop taking their medicine, but that has been reported. We have to figure out what's going on there. And when you crack that immune barrier, then you'll see this whole world of composite tissue transplants open up.
What would you say is your defining case? The case that makes you feel most proud or excited about what you do?
Can I get two answers there?
Yes, I'll give you two.
I might even ask for more. I really like microsurgery, and I like replanting amputated digits. I really just think the 5-fingered hand is just the best. And if I feel like the part's in good condition and it's a motivated patient and we can save the finger, I like to do it. And we can do it. I mean, that's where we are. It goes back to what I was really taken with in medical school. It's restoring form and function. And then, along those lines, I like rebuilding the thumb like we talked about before. I just think that's really awesome. Very similar to replants. It's almost like an elective replant, where instead of the digit getting harvested with a saw, we are doing the harvest. So we're taking the toe off our way and then bringing it up to the thumb. So it's very similar to replant. So I'm going to put those two in the replant category. And then my second answer would be, well, I really like complex cases in general. And so I like being given the opportunity to help other people with challenging cases. That's what I'm really taken with. That's what appeals to me in this world is, you get trained up to the point where you feel comfortable taking on complex cases and helping other people out with challenging cases.
It's always exciting stuff. All the coolest stuff that we're doing here really does happen at the Curtis Hand Center.
Yeah.
Thank you.
Yeah, thank you.
We've been talking with Dr. Ryan Katz, attending hand surgeon at the Curtis National Hand Center here at MedStar Union Memorial Hospital in Baltimore. For more information on hand surgery or the extraordinary work performed at the Curtis National Hand Center, link to it on the MedStar Health webpage. That's medstarhealth.org. Or for an appointment with Dr. Katz or any hand surgeon at the Curtis National Hand Center, call 410-554-6560.